everyone.
Oh, hold it, wait, not, I think it's just gonna take a minute.
Okay, it says it's.
Yes.
Okay. Hi, everyone. I'm Assembly Member Linda B. Rosenthal. I represent the 67th Assembly District, the west side of Manhattan, and Hell's Kitchen. And I'm joined tonight by my colleague, State Senator Brad Hoylman. This is the second in our series of virtual town halls on the COVID-19 virus. We are joined again by Professor Paul Binoche, PhD, Professor Theodora Hazianu, PhD, and Professor Vincent Racaniello. And they are our experts once again, and we welcome you to our town hall. So I want to thank everybody who is logging on now for joining us. And, we will try to hold these every Sunday night at 8 p.m. While this crisis continues. We've gotten feedback from many viewers who really enjoyed hearing from the experts and like this format. So we're going to try to do it as well as we can in the future. New York State continues to take dramatic action to contain the spread of the virus. The total number of cases today in New York State are 15,168, with 4,812 new ones just today. The New York City totals are 9,045 cases with 2,832 new cases today. So I believe New York State has the largest number of people affected by this COVID-19, and that number will only increase as our testing capacity increases. I know I feel anxiety, and I am sure that others out there are. There's sort of an information overload, but also which sources should we trust? And so that's why we really appreciate you joining us to provide us with accurate and trustworthy information. So I'm going to throw back to Brad now, and he will introduce you, and we'll get right to questions. People can submit their questions on Facebook, and we'll intersperse them with our questions. Okay, back to you, Brad.
Your mic is not working.
Not working. Okay.
Now it is.
Okay. Thanks very much. Sorry. You'd think I'd figure this out by now, but thank you, Linda, and thank you to our panelists. I just wanted to read brief bios of our panelists tonight to know a little bit about them and their expertise. Paul Binoche, PhD, he's a professor investigator at the Howard Hughes Medical Institute at the Rockefeller University. His research topics include cell biology, immunology, virology, microbiology, and the mechanisms of human disease. He studies the biology and evolution of retroviruses, including HIV-1, and the genetics of host virus interactions. Sitting alongside him is his partner, his spouse, Theodora Hazianu, PhD. Theodora is a research associate professor at the Rockefeller University's Laboratory of Retrovirology. Her accomplishments include being part of the first research team ever to develop an HIV-1 based virus that's able to cause an AIDS-like disease in a non-human, helping us further understand the HIV/AIDS virus. What kind of species was it?
It was a macaque. It's a small
macaque.
monkey.
Oh, is a macaque one of the potential sources for COVID-19? Am I wrong about that?
I don't think so, no.
Okay, I thought, okay. And then Vincent Racaniello is the Higgins Professor in the Department of Microbiology and Immunology at Columbia University's College of Physicians and Surgeons. He's done laboratory research on viruses for more than 40 years, starting with his PhD program at CUNY and continuing to this day. He studied many viruses, including influenza and polio. And of all the viruses you've studied, is this the most complicated?
You mean the current one that's causing this pandemic? Is
Correct.
that the most complicated? No, I think they're all complicated, but this one is very frustrating at the moment.
So I wonder if you'd explain to us, in just 7 days, the number of COVID-19 cases in New York has skyrocketed. Why is that?
We're doing more testing. We weren't testing before.
Yeah. Undoubtedly, there's been spread, but the main driver of that very dramatic uptick is clearly testing.
Okay,
And
it seems
I think we also only
sometimes you see on
Go ahead.
I think
She's frozen.
Linda's frozen.
She's frozen. Go ahead. Why don't you go ahead, Theodore?
I
Yeah.
was just saying that, yes, everybody predicted that we would have this dramatic increase because of the increase in testing. Okay, but I still think that in terms of the population of New York City, is still only a tiny little bit of what this virus could potentially spread. Oops.
I think we have a technical difficulty. Linda, you might want to log off and log back on. I'm not sure. But I wanted to ask you about the tests. And do you think that the virus has been circulating in the population for months longer than we would have thought? I think you said last week in Washington State, there was an example of it in 2019. Do you think it's been in New York for months?
It's possible. Very hard to say, but yes, it is possible.
Well, I think since it's very likely because it emerged way back probably in November now in China, and the first case in Washington was in January. And since we weren't testing here, I think it's been here at least since then. I'm hearing now reports of illnesses consistent with it back early in the year. So I think at some point in the future, when we do some testing that'll reveal that, they will probably show how long it's been in here.
Just for the viewers who might have been, logging on for the first time, I know we discussed it a little bit last week. Could you give us just a basic summary of COVID-19? What sort of virus is it? What's different and worse about COVID-19 than other viruses like the flu?
Vincent, Professor.
All right. Let me just clarify, though. COVID-19 is the disease caused by SARS-CoV-2, which is a coronavirus. So SARS, some of you may remember, there was a virus that emerged in 2003 that caused an outbreak. It was called SARS coronavirus. And this is similar but different in many ways. It has some animal origin. The original SARS coronavirus came from a bat via a civet. This one most likely a bat, but we don't know if there was an intermediary. They both cause respiratory infections. Both viruses can cause also gastrointestinal infections. The main difference, which I think is really important, and which is why SARS-1 stopped after 11 months or so, 8,000 cases, 29 countries. It made people very, very sick, and most of them had to be hospitalized where infection could be contained. This one is community spread. A lot of people are not very sick. Over 80% of the cases are mild. People are walking around spreading virus without being sick or being minimally sick. And so it's being spread far more extensively than that other virus was. Is
there something in their biology that makes them virtually immune to it? I mean, what other than these pre-existing conditions which we read about, is there something about someone's personal biology that may make them only basically be asymptomatic?
That's a really good question, right? We'd like to know that. we don't understand a lot of the aspects of the disease. And a really interesting question is why very young kids don't seem to get very sick. I think we mentioned that last time. It's mostly older people over 60. We don't understand. A lot needs to be sorted out. I mean, this is only a virus we've known for a few months now, so it's going to take some time to do that. And really, most of the emphasis is on diagnosis and developing therapeutics for now.
And I've been reading about the fact that they want, the FDA and others, and I think New York has just applied for this potential of examining an individual's antibodies if they've survived the illness, and using that as some sort of template for research. Is it possible that an infusion of a survivor's plasma into a sufferer could help them recover from the condition?
Go ahead, Paul and Theodora.
Yeah, that is. So that's indeed something that's being looked into. There's a project in Baltimore. There's also a project just getting off the ground here in New York City. So when somebody becomes infected and then recovers, they have an immune response that we fully expect to make them resistant to reinfection for some weeks, months afterwards. A big component of that immunity is something we call neutralizing antibodies. So antibodies are things that we carry in our blood. They bind to virus and essentially stop it from infecting cells. And there's a long history, really even before we knew about viruses, of using plasma, blood plasma, from people who have recovered from a disease, transferring that plasma to recipients and as a treatment and potentially even as a prophylactic infection. So as the epidemic ramps up in New York, there are indeed projects underway to see whether that's feasible and of course to test whether it's effective. Obviously, protecting our healthcare workers is high on everyone's list of priorities, and being able to do that with what we call convalescent plasma is in the absence of in the absence of drugs that we know to be effective. It's something that's being looked into.
That's fascinating. It's obviously not scalable, but it's something that
one would think it's not scalable, but we have a huge apparatus for blood donation that could be mobilized for precisely this end. You know, obviously you need a pool of people who have recovered from being sick, which we don't have very many yet. But as the epidemic evolves, those numbers will increase.
We should mention that this is exactly one of the projects we are involved in at Rockefeller University, and the university has released a call for people that have recovered from SARS-CoV-2
Really?
if they wish to act as volunteers. So we would screen their blood for these antibodies that would neutralize or incapacitate the virus.
And where would these folks find you? Like at the Rockefeller University website?
Yes, at the Rockefeller University website, they can either come, their numbers for contact are there, and if they don't feel comfortable coming to the hospital, there is a potential team to go to them. So
fascinating.
Over the longer term, a sort of a more technologically refined and perhaps more effective way of doing this wouldn't simply be to transfer the plasma from people who have recovered, but to actually clone the genes encoding those neutralizing antibodies, make those antibodies in large quantities, and then one could have a much more reproducible, steady, and demonstrably effective supply of protective agent. Obviously, that takes some months to get off the ground, but that's a project that Rockefeller and many other places around the world are seeking to do exactly that, to use people's immune systems as a source of protection and treatment.
I think the Assemblywoman is logged back on. But in the meantime, everyone keeps talking about flattening the curve. And, you know, this is the reason that Governor Cuomo has closed businesses and canceled gatherings of all different sizes. Can you just remind us what it means to flatten the curve?
Yes, so we're just plugging some numbers here. So the problem, one of the problems of this particular pandemic, of this particular virus infection, is that a large percentage of infected people, yes, most of them will be asymptomatic, as Vincent mentioned, but actually quite a large number will require hospitalization. And a percentage of those people will require ICU. So they require respiratory, they require serious intervention. So if all those people get sick at the same time, we don't have enough, the New York City hospitals don't have enough ICU beds to treat everybody. If, however, we really practice extreme social distancing and try to delay the spread of the virus, because the virus will spread, we can stagger the number of people that get sick and require hospitalization over a very long period of time. And essential care infrastructure, it doesn't collapse by the sheer number of people that will require treatment. That's what flatten the curve means. That means everybody has to really take this social distancing very seriously.
So there's an additional benefit I'd just jump in and add. So things like using convalescent plasma to protect people. The more you flatten the curve, the better opportunity there is for those interventions to take effect.
Great, thank you. We got to have a bunch of viewers who are writing in questions. One from Teresa. Is doing laundry in a laundromat safe? And what if the laundry is wet?
Don't touch your face.
Who wants to take that one?
I don't know.
So I would say that if the laundromat is crowded with people, maybe wait for another day to do it. I would say regard the surfaces that you touch in the laundromat as being potentially infectious. So you could wipe down the parts of the washing machine that you touch. However, I'm attempting to read between the lines. I think once the clothes are in the washing machine, in warm water, most importantly with detergent, that should be a very effective way to neutralize the virus. Similarly in dryers, if you have the temperature stay high, that again should be sufficient to inactivate the virus. So there's not a specific risk, I would say, in terms of doing laundry. There is a risk in terms of being in an enclosed space with a number of people.
Right.
Yes.
Right. Linda, welcome back.
Thank you. Yeah, technical issues, as they say. So I don't know if you asked this already, but this is concerning outside activities, going outside. And so, you know, we've been cautioned and reprimanded as a city and as a state that we have to be very careful outside. You can't walk next to your friend or next to a stranger. You're supposed to have 6 feet between you. And I was out yesterday and I saw people, quarreling over items in a food store, and people are not listening to the advice, actually the obligation to stop the spread by not walking around and congregating as normal. And I wonder if you could talk about that some more, about why it's important, why it's crucial that people listen to that.
Because it's the main mode of transmission. Like if you are close to another person, at this stage, for me, and I think a lot of people would agree, you need to treat everybody as potentially infected. You need to assume that the person that's there fighting for the same, I don't know, can of tomatoes or whatever, you is to avoid being in contact with them. And this person-to-person spread is the mode of transmission of this virus, the best way this virus gets transmitted. So that's why you need to stay away from people. And I think that this is a problem. And I have seen the measures getting progressively harsher and harsher about the instructions about what to do with social distancing. But in the end of the day, you always have people that will not listen and will not pay attention. So perhaps what San Francisco is doing is like really stay at home and everybody is confined is the only way to get people to limit themselves.
It might be useful to add that, you know, people may think, oh, the person next to me is not sick, I'm not going to get infected by them, but they could be infected, not showing any symptoms, yet with every breath they take, they're exhaling droplets which contain virus. So you can have spread even from a person who appears completely healthy. And that's the insidious nature of this virus, that it makes people don't appear to be sick all the time, and they're still exhaling the virus and spreading it. So you really need to distance from other people.
It also seems connected to a certain amount of denial. Well, I'm fine, my friend looks fine, the stranger looks fine, so they can't possibly transmit COVID-19 to me. And as you all said, it's absolutely false. And that's why we have to listen, or else we will be shut down, I fear. And so listen up, New York, stay inside. Go ahead.
Yeah. Oh, sorry.
It has to be, sorry, I think that it has to be imposed. I mean, I just don't see everybody complying with this voluntarily. And you're one person to take this lightly, to have a potentially huge spread. The other thing I've heard from groups of people that still get together and look relatively young is this, oh, this is a disease that old people will suffer from. We are relatively safe. That is not true. 48% of hospitalizations occur to relatively young people between the ages of 20 and 54. So
Yeah.
you're not immune to this.
Yes. Yeah,
I mean,
they're taking the invincibility of youth and wrapping themselves in it, when in fact it may have been true earlier that young people didn't get it, but what we're seeing now is no one is immune, actually.
Well, so this question builds on what Linda had just been saying from one of our viewers, from David. He's asking about an enclosed space, maybe a laundromat, where people have been but have since left. How long does the risk exist? Vincent, you talk about droplets in the air. Is this something that's seconds, or can they be circulated through ventilation systems, for example?
For the most part, the droplets that seem to carry this virus are relatively large, and they fall to the ground within 6 feet of you. So they don't stay suspended for indefinite periods. So I would say within minutes they're on the ground. Now, the effect of having circulating air probably doesn't have a huge amount of influence, but it will suspend them longer than if the air is still. But, you know, if you go somewhere and there's no one there and it's clear that there's been no one there for a while, the only potential sources of infection are the surfaces. You know, public surfaces are touched by many people, and I would treat every public surface as a potential vector of infection. And just, if you have to touch them, make sure you don't touch your eyes and nose and mouth until you can wash your hands. But I think if people aren't in a space, it's not going to be filled with viruses floating around.
So we shouldn't be concerned if there is a central air conditioning system in our building, for example?
I think not. I think there's a story, some information from the SARS outbreak of many years ago, where infections were transmitted on airplanes where the air is circulated extensively, but yet when there was an infected person sitting in the seat, it's only the people around that person who were infected, which suggests just local transmission was occurring. So I don't think that there is widespread recirculation of those larger droplets.
And Phyllis has asked, how big of a risk is it for one of these seniors that Linda mentioned to say, go to the supermarket if they keep a distance of 3 to 6 feet? Did you see a lot of risk in that kind of visit to a local grocery?
I think that's pretty risky for an older person. I would get someone to go for you because you're going to touch your face and nose. It's really hard not to. You're going to be touching the cash area where you have to put your number, your PIN into that machine. That's probably heavily contaminated. There's going to be a cashier you have to be near. So I wouldn't, if I were older, I wouldn't take that risk.
So it's the surfaces more than the air and distance that you're concerned about.
Yeah, I think it's hard for people not to touch things. And of course, all the things you buy are potentially contaminated. We talked about that last time, and I would treat them as potentially contaminated. And I think for an older person, that's just a little bit too much danger because we know how severe the infection can be in them.
Yes. So Victoria is asking, she has a child care person who comes from the suburbs to take care of her child and then leaves and then comes back the next day. Does this sound like the wisest arrangement?
How does the child care person travel?
She doesn't say. She just says comes from the city to the suburbs. So
No.
Address both. If it were her car, that would be one thing perhaps, and public transportation a different thing.
So I believe that that activity, you can correct me if I'm wrong, that would be prohibited from rules that go into effect this evening.
Probably just starting 8 p.m. I guess starting since we began, that really shouldn't happen.
So
and she'd have to find another source of childcare or stay home herself if she could.
So this might be a good point at which to sort of talk about the general aspects of risk and what it actually means to get this epidemic under control. So in order for us to get the upper hand against this virus, essentially every infected person has to transmit the virus to less than one uninfected person. There's a scientific term we use called R, the reproductive ratio. And if each infected person infects more than one other uninfected person, you have an epidemic that spreads. So that number R is affected both by the biological properties of the virus itself, how infectious it is. We know this virus is very infectious, but it's also affected dramatically by the behavior of people. So our major weapon against this virus at the moment is simply reducing the number of people that we come into contact with, to reduce that average number of people that each infected person transmits virus to a number that's less than one, okay? If we do nothing, we have estimates of what this number is from the city of Wuhan, for example. That number is between 2 and 3. And that creates the potential for an explosive epidemic. So the whole basis for social distancing is to reduce the number of people you come into contact with. So in this particular example, having a childcare provider who's traveling perhaps on public transport each day, that's massively increasing the number of people that person is coming into contact with. And every person that does that drives up that R number and makes it tougher to control the epidemic. So these rules are, they're not just to protect ourselves, but they're a sort of a responsibility of the entire community to work together to drive that number down so we can get on top of the epidemic.
And maybe we could discuss a little bit about the healthcare force, the nurses, the physicians, other healthcare professionals who are in constant contact with people who have the virus, and what the effects of that are, not only on them personally and their families, but on the whole health, if you will, of the healthcare system.
No, that's sorry. Go ahead, Vincent.
So let me give you the perspective from being near Columbia Presbyterian Hospital, where they have currently 550 SARS-CoV-2 positive patients. They're testing about 500 every day. So a lot of people are in there and being cared for who are infected. And just to give you a sense, if you were in a room and you're in a hospital room and you're infected, whoever goes into that room has to don protective gear to do whatever they're going to do to you. And then when they leave, they throw it away. Our hospital is going through 50,000 face masks a day alone, just for that procedure. At some point, I'm very worried that we're not going to have enough equipment, and that will put the healthcare workers at risk, which is the last thing we want. The more infected people there are in the hospital, the more likely it is that some healthcare worker will be infected. And we can't afford it because we need them to take care of sick people. So that's my biggest concern, actually, in this outbreak, that we won't be able to care for people. Not only that, but also to care for the healthcare workers themselves. And so the fewer people who are infected, obviously, the better off that they're going to be.
Wow, that's amazing, Vincent, that you're saying that about 50% are coming in with COVID-19 symptoms. Is that
Yeah,
right?
it looks about that here in the city. I think in other states it's lower because the population is lower, right? But it's not a surprising number, actually, and it's a lot. It's a lot of people.
Well, what is surprising you about this so far? And Annie asks from the questions, she's asking, what's a question that no one is asking about COVID but should be?
Well, I'm of all the questions I have, the one I would like to know is how long this has to go on, or this will go on, because, you know, if we're all at home for weeks and weeks at a time, that has other tolls that they exert. And one of them is the psychological toll. I think we're going to have a lot of issues after this from people staying at home, but this can't go on forever. And no one is yet addressing it. There's no plan for going beyond the next week or so, which is understandable. But I have lots of scientific questions, but for me, that's the most pressing, because if you think about it, you can't handle something going on forever in your mind. And so when does it stop?
Yeah.
And
Well,
when do we think, you know, we've heard, and correct me if I'm wrong, Brett, they said 45 days it would peak. Has there been a reevaluation of that time frame?
Yeah, what's your best and worst case scenario on when you think the virus might peak?
So this depends on, I think that I agree with Vincent, but this depends on how people behave. So if people continue to ignore the advice about social distancing, continue to mix, as Paul pointed out, we will not get on top of this. And then imagine if you think that, I don't know, even 50% of New York gets infected. Nobody's getting out of their apartments ever again. So stay indoors now, and we might have a small chance of containing it. But if you continue to ignore the advice and continue to mix and continue to spread, then we're going to be stuck with these regulations for a really long time. And then the impact of such measures is going to be even greater, both in the economy and everybody's life.
So I'd just add to that. I was looking at some statistics today from countries or regions that have been sort of the poster children for getting on top of the epidemic. Places like Hong Kong and particularly Singapore have really managed to, through fairly draconian social distancing type approaches, widespread testing and so on, have been able to keep the number of cases very low, in fact, compared to other countries and regions. but the numbers are just beginning to creep up now. And a sort of a hypothesis that what's happening is that there's really fatigue with this imposition of social distancing.
So
you know,
needless to say, you'd be supportive of the suggestions that we close streets to traffic and pedestrians.
Yes, I would. But like Vincent, I'm a little worried about what the long term is going to look like. How are we going to go back to work? And at the moment, no crystal ball. We're, as we said last time, flying blind a little bit. But I think at this point we just have to do what we can. In New York, the rates of infection are sufficiently high that at some point in the not too distant future, we might have a cadre of people who have been infected and recovered and are at least temporarily immune. And we might have to think about imagining to use that workforce to help society get back to some semblance of normality.
Wow.
But for right now, it's going to be a tricky issue for some time.
We have a question here from Jonathan, who says, after the number of hospitalization drops at some point and normal daily life returns, won't there still be a significant number of asymptomatic persons to start a second wave? So first question, do we know in fact that you can't get it again after you've recovered? And two, what do you think about the prospects that there will be a second wave?
I would say that we should assume that you're not going to get it once you have it the first time. You know, there have been some reports out of China that people are being reinfected, but frankly, I don't believe them until I see the data. Most virus infections we become immune, and we don't get it again, at least for a while. So I would assume that. And the point is, if this epidemic goes on for a while, enough people will be immunized so that even if there are asymptomatic people walking around infected, they won't find someone to infect. There won't be enough susceptible people around them to transmit the infection. That's the whole theory behind, you know, reducing that reproductive number that Paul was talking about. Can be also done by becoming immune. So I don't worry about a second wave unless there are a lot of people who were not infected the first time.
Okay.
And one way to really get on top of that is to make testing easier, more widespread, to make testing more routine. And there are, I understand, some rapid tests in development, because you know, one could imagine a scenario where many people, perhaps a large fraction of the population, is regularly tested, and if you turn up positive, you self-quarantine on an individual basis rather than as a society-wide basis.
I guess we're gonna see the second wave possibilities in China, where people are beginning to recongregate and take mass transit and know if, you know. But I remember what you said last week, Vincent, that at the very least, we don't think the virus is going to mutate because it's pretty efficient as it already is and doesn't really need to.
No, it's not going to change in ways to make it worse or more transmissible, because it's just wonderfully transmitted this time, the way it is already. And yeah, I worry about second wave in China, but I'm not sure to what extent everyone's gone back to work yet. So we just have to wait and see.
You know, we were talking earlier about folks who are older and going to the grocery store. If someone wants to volunteer through either Assemblywoman Rosenthal's office or mine, we're going to put it in the comments below on where you can sign up and possibly go get groceries for an older person who might not want to take the risk. What do you think about, describe to us, when you're watching these press conferences, with the President of the United States and Tony Fauci, longtime eminent virologist, infectious disease specialist. Do you believe that the CDC is bending under Trump's will, or is the science that's being put forward and the recommendations, do we have the guardrails of academics and experts like yourself for the Americans to understand that this information is the best and is correct?
Well, let me just say that
So I'll try that one. Go on.
Anthony Fauci is, in my view, a hero. Whatever he says, I believe, and we should be following his advice. He's been yelling since January that we should be doing something, and we're only now listening, and we're catching up. We're making it up as we go along. We should have responded in January. We would not be in the position that we are in now of having to do all of this if we had responded initially like South Korea did. They started in January. They started testing. They started ramping up hospital capacity. They started restricting movements, and they got away with very few infections. And what are we doing? We're catching up. It's absolutely crazy that our country is in this position. That's what I think.
And where do you think the information, for example, about the lupus drug that Trump mentioned as a potential, cure? I know, yes, you're covering your eyes. Where is that coming from?
So I can take that one. There was actually a scientific paper that was published over the last week that reported a clinical trial of sorts where some patients were given this hydroxychloroquine. And I won't go into all the technical details, but this was a highly flawed experiment. So whenever you have a drug that's a candidate for a treatment, there are well-established ways to test the effectiveness of these agents. You randomize patients to either receive or not receive the drug, for example. This clinical trial clearly didn't follow those rules, and as such, the scientific paper that was published was in my view very flawed and actually didn't demonstrate anything conclusive. Unfortunately, that has been seized on by the president and others as demonstrating that this drug may have effectiveness. It may have effectiveness, but we simply don't know at this point. We need to do proper clinical trials of this and any other new drug that comes into potential utility. There's obviously a desire to do something. The urgency of the situation compels us to try to find things to treat and prevent this disease. But the worst thing we can do is to deploy treatments that aren't effective or even dangerous, as might possibly be the case in this instance. And so we have to proceed very carefully, trust our medical health professionals to do the trials that will demonstrate whether these drugs work or don't work. And so while there's this obvious desire to do something, we have to have some patience and let the process work itself out.
Yes, as I just mentioned that what Linda said when we started, that yes, we also scientists get a lot of misinformation. There is this enormous rush from, probably driven by the need to feel useful and to contribute to this fight. But as a lot of things that are being put on, published in open access websites that have not gone through peer review, because normally our papers go through a review by other scientists before they're published, but this is kind of not the norm now. So there's a plethora of information and it's very hard to Do we have to go through every paper, look at the data, look at the figures and say, yes, this makes sense, or say, yes, I believe the data. And then to second Vincent, yes, I would believe anything Fauci says. I'd follow him to hell. I mean, seriously, he says that's honestly.
We may be going that way. Not to be too pessimistic, but he's been, for decades, he's been absolutely a star in this field. But I'd like to ask about, and we have a question from Dylan about marginalized populations. So we have a bit of a raging discussion here in New York City and New York State about releasing people who are incarcerated from prisons and jails because they're like a breeding factory. If one has it, they all spread it because they're so confined. And that's the first question. What should we do? And the second is about homeless people who are so vulnerable. They don't have a place to call home. It's a sidewalk, and they live in less than sanitary conditions. And what can we do for them as well as those in shelters? It seems that they are the most vulnerable, and yet they are the ones probably who have the least access to any kind of resources. So the prison issue and the homeless issue.
Very hard to answer for us scientists. I mean, this is
It's a disease spread, like keeping people in prisons when it's so confined and people have COVID-19.
Of course, and there's clearly perhaps some not so dangerous criminals that you could potentially release. I wouldn't be so happy about releasing mass murderers, even with the threat of the virus. But I mean, it's just, this is such a complicated issue that has always been there. It's just that the disease is making it come to light.
Come to the fore, yeah.
On that specific point, this was a topic in the press conference this evening. There is under active consideration a measure to release older non-violent criminals or inmates. That I think absolutely should be done, because they're obviously those that are at the highest risk.
Yeah. I mean, many people in jails are just either violated parole, or it's some technical or minor crime. And they're, you know, in some places there's talk that they will be released, but in other places around the state, there's no decision, which means the disease can multiply as long as, you know, till a decision is made.
So I don't know what the best decision. Yeah, again, the advice would be that any measure that can limit the spread should be
taken, yes.
Taken into serious consideration. And every day we delay making those hard decisions is a day the virus spreads more. So
yes.
That being said, if you are going to release inmates, I would make sure you check them, you test them first to make sure you're not releasing infected individuals into the community. That would be even worse, I think.
Yes, well, that's true. Where would they go? And we have to make sure when and if they're released, that they go somewhere where they can actually recover in their beds or at home, or whatever home is for them. I know about somebody. Yeah. Go ahead.
The other issue with homeless shelters, I think the answer to that is the same, is testing. Okay, basically removing people from the population and giving them somewhere else to stay if they test positive, because obviously in a group living situation, that's obviously where the virus is going to spread most dramatically. So there are promising signs in New York with the number of tests increasing, but we have to get to a point where I would say everybody in a group living situation gets tested reasonably regularly.
Yeah.
Speaking of testing, what is it you're looking for? You take the swab, you put it into some sort of solution, then it's sent off to a laboratory. Scientifically, like, does someone take that and look under a microscope, or is it put into a culture?
No, we amplify the genetic bits. We look for bits of the genetic material of the virus in the sample. We have a very sensitive technique called polymerase chain reaction, which actually amplifies pieces of genetic material. And we can do that and detect and see whether there is virus there or not. And if there is virus, it mehave you're infected. If there isn't, it means you're not infected.
Mm-hmm.
It's so interesting. This is the new positive, right? I mean, those who have studied HIV, I do a double take when I hear somebody say that, you know, so and so tested positive, because for the LGBTQ community, that meant something obviously very different for so many years. But we don't know yet, and we talked about this last week, whether people who are HIV positive are necessary and have a normal CD4 count because of antiretroviral drugs are necessarily more susceptible to the virus, or in a class of folks who are endangered.
That's, as far as I know, not known yet, at least not known to me. Just a further word on testing. The type of test that Theodora described is more akin to the sort of viral load test that HIV patients often receive. Epidemic goes on. What will come into play is a test for antibodies to the virus, which will tell you whether somebody has been infected and whether they've recovered. Obviously, that there are two very different kind of tests. One test for the virus itself, and one test for an immune response to the virus. So when you say someone is HIV positive, typically that means they have antibodies to the virus. So in the case of HIV, once you're infected, it's a lifelong infection. So you'll always be virus positive and antibody positive unless you have drugs that suppress the virus to undetectable levels. With this virus, you're going to be virus positive and then antibody positive, but the virus is going to be cleared. Okay. And
the antibody test is not necessarily, well, obviously you're recruiting people at Rockefeller, correct?
Yes.
And you would have them undertake an antibody test. Is that what you would do for those who have recovered from the condition?
Yes.
Right. For that specific purpose, yes. And the antibody tests are beginning to come online now. They'll soon be widely available, I would expect.
So I have a question about HCQ, hydroxychloroquine. Is that how you say it? Okay. And so I've heard anecdotally about people who suffer from rheumatoid arthritis and lupus, and that, well, first, that they now can't get the doses they need. This is in another state because they're being diverted to trials with people with the virus. And I guess we acquired 70,000 doses of it to start trials. Can you discuss that? The use of that drug, and what evidence do we have that it works or doesn't work?
So that is the drug that the study that Paul mentioned, that
Yes.
it was not good. So that is the actual drug.
So
Okay.
there is, what I should qualify my comments by saying there is a rational basis for thinking that that drug might work. We have a fairly good idea what that drug does to cells. And it's also known that when you do what that drug does to cells, and in fact, it's been tested in cell culture, the drug does actually work to inhibit the virus in a cell culture, in a laboratory setting. But there's a world of difference between having that information and knowing that it works in a patient. For example, we know that this class of drugs inhibits influenza virus in cell culture, but when it was tested in people, it didn't work. Okay, so
are we using it? Are we doing tests with it, or is that not correct?
Ongoing now.
Yes.
as they should.
Okay.
Well-designed trials.
Okay, great.
Vincent, you were mentioning, we have a question from one of the viewers about personal protective equipment. And Vincent was, before we started the chat, you said that physicians at Columbia Presbyterian are going through and workers are going through about 50,000 face masks a day. Is that what you were saying?
Yeah, that's right. Because every time you go into a patient room who's infected, you have to put it on and then you throw it away. You do that every hour. You can see it adds up if you have 500 patients and you go in every hour. That's a lot of face masks. And I'm just concerned that we don't have enough because we haven't been prepared for this. And the worst thing that can happen is that we run out. So, the FDA is trying to mobilize face masks and regulate production of face masks by various companies. And that's all good. It's a bit late. Should have been done in January. We should have a face mask stockpile, right? We have many other stuff. We have an oil stockpile. We need a face mask stockpile.
A strategic face mask stockpile.
That's right. That's right.
Or reserve, I guess. Strategic face mask reserve. The governor has asked the president to put American companies to work to manufacture these. I think New York State is paying about $7 a mask for some of them that normally would sell for 85 cents an item. But Trump is still urging states to go on the open market. In our districts, Linda and I have helped facilitate face mask donations just so that the viewers know that to local hospitals. We actually were in touch with the FDA about a huge cache of face masks that were stuck on the Mexican border and unable to be imported due to various regulations. But it's a very vexing problem, and I think you're right. This should have been addressed a long time ago.
We have a question from Maggie who asks, do seniors need to isolate until there's a vaccine? And recalling what we said last week, a vaccine is in the future. So someone would have to isolate for maybe even more than a year. Is that right?
Yeah, that's right. So I don't think that's a realistic expectation for anyone to be isolated for that long. I think we have to wait and see when. Right now, the cases are increasing substantially every day. We're going to get to a point where they're not, and they level off and decrease, and then people will make a decision about when it would be safe to stop. But you can't wait for a vaccine because that's 2021 at the earliest.
Yeah. Yes. So I have a senior living facility in my area, and I've been told that some of the workers who walk around without masks, some of the residents are quite elderly, 80 plus. What would you say to them? And I spoke to the director. I said, everyone has to wear a mask there. And could you expound on that a bit?
I think if people are coming in from outside to work in these facilities, they absolutely need to wear masks because they have the potential of being infected outside of the facility and bringing it in. They could be asymptomatically infected if they're not tested. So they all should be wearing masks. They should be instructed how to wear them properly and then instructed how to take them off, because those two parts are critical, because you could contaminate yourself. So I would think they all should be wearing masks.
Okay, that's a good point to emphasize, because people are not taking this as seriously as they should, and none of us is invincible. Even the most healthy person can come down with it. I mean, we've heard it's people with compromised immune systems, underlying health conditions, but they may be the most at risk, but that doesn't mean that others are not at risk. Is that right?
Yeah, and I think you should take an example from Italy, where they've had massive increases in the number of cases and incredible numbers of deaths daily, mainly in older people. They have a huge elderly population there, and it's just frightening. So I think people who think it's not serious should just look at Italy and see what's going on there.
We have another question here from Elizabeth. She asks, why is New York City limiting tests to people who are hospitalized when our scientific community say that we should be testing everyone possible. Is that what you're saying? We should be testing everyone?
We don't have enough tests.
It's simply capacity. The capacity is ramping up, but it needs to be more.
The FDA's developed a new, or has okayed a 45-minute result test. It's a new test, right?
I did, yeah.
I think I heard that yesterday on the news show. So that
I haven't seen data as to how it performs, but obviously, convenient home testing, doctor's office testing, that will be a big part of the fight as we go forward through the epidemic.
But something
is it possible for a physician to make a clinical diagnosis of COVID-19 without the actual test?
No, it's not possible. The symptoms are so much like other respiratory infections. It's virtually impossible. Only in very few cases when the presentation is different, you have a guess, but you always have to test in the end to make sure what it is.
Yeah, there's influenza-like illness, which covers a whole range of viruses. Having influenza-like illness with a negative influenza test, it would be one indication.
It seems people are being tested first for influenza in some cases, and then if they're negative, then they go on to the next COVID-19, right? Is that why is that?
I think it's mainly because we don't have enough tests for COVID-19, and so if they're unfortunately, it's not a good practice because they may have both. If they have a positive influenza test, they could also have SARS-CoV-2. So the best thing that can happen, at least in a hospital setting, there are what are called multiplex assays. You can look for a whole range of respiratory viruses. So if someone comes in with a respiratory illness, you can take one sample and look for 20 different viruses. And unfortunately, the SARS-CoV-2 is not yet part of those panels, so it has to be tested separately. But as soon as that comes online, which should be, within this outbreak, that'll really help enormously.
Yeah. Richard asks if the virus is suspected of causing permanent physical disabilities, permanent lung damage, for example. Do we know that answer yet?
I think Vincent might know.
Yes, I asked someone that just on Friday, and it's still very early to tell, but the virus is damaging lung cells, and so the physician I asked said he'd already had some recovered patients and looked like they were going to have at least short-term permanent lung damage, and how long that goes on we don't know yet because we don't have enough experience, but the potential is there for sure. Yeah,
and people who smoke and vape probably should stop doing that, would you say?
Absolutely. I mean, we know smoking increases your susceptibility to respiratory illness, and vaping as well, so you shouldn't be doing it during this outbreak for sure.
Can I just add one thing about the symptomatology of presentation? It's becoming a little more clear that there's a subpopulation of patients that are presenting with fever and diarrhea rather than respiratory.
That's right.
And so that's an extra sort of set of symptoms that people should be on the lookout for. Not simply flu-like illness, but diarrhea seems to be an important component for at least a subset of patients.
And that begins earlier than some of the other symptoms, is that right?
It can do, it can.
Yeah, so keep close watch on your body. Yeah.
We're reaching the end of our hour. A couple of lightning round questions and then we'll close it out. From Audrey, should we be donating blood right now?
Yes. So there's still people getting sick with other conditions. I am sure the centers will be screening for this virus. But yes, the need for blood did not go away. Now, obviously, hopefully the blood centers are taking precautions to
Protect.
stop people congregating. But yeah, it's important that we don't compound the problem by creating another problem with the blood shortage.
Mhm. A couple of questions on whether food that is cold needs to be wiped down or washed with soap and water.
What food?
I guess like if you buy poultry.
I mean,
Um, how about a milk container in a refrigerator? Would you wipe that down like you would
I wipe it
cardboard,
down. I wipe it down.
even if it's cold?
Yeah. Oh, yes.
Okay. And then my final lightning round question is is it true that you can catch the virus from someone by simply passing them in the street, even if they aren't sneezing or coughing?
Yes. Remember, we said earlier, if you're just breathing and speaking, you're exhaling these droplets. So if you pass someone very closely, chances are that you might inhale what they've exhaled. So yes.
That is frightening. That's
No, particularly-
absolutely frightening.
I noticed the other day that the number of people running has increased. And of course, all these people running breathe a lot more heavily than your average person walking. So it's really, and they also run, they don't always keep their distance. So we're just getting really worried about
So
crossing
Hudson
those
River
lines.
Park is chock full of runners every evening.
So
People should not be doing that. That's
Should
interesting.
the risks in the open air are less than they are in an enclosed space, but they're clearly not zero.
Yeah,
Well, I just
you
wanna-
may decide you will be fit, but if you don't live, it won't matter. So that's basically, I think, one of the big messages we're trying to send out tonight is listen to what the experts are saying and stay inside. You know, whether you're 70 plus and you really should not go out at all, or you're younger, just stay home. You know, we always yearn for time off from work, a time to relax. This is imposed, so it doesn't feel as much fun, but it really will save your life. And
Yeah.
I think people ought to heed that.
Yeah, and I just want to thank our expert panelists. And I'll close with one plug. Vincent has a podcast, right, Vincent?
That's right.
That is weekly?
It's a weekly pod. Well, actually, it's more frequent now because of the COVID epidemic, but it's called This Week in Virology. And we have all kinds of interesting people explaining the virus, the disease. The last one we had released today was with a clinician, an infectious disease physician who's treating hundreds of patients here in the New York area. Has great experiences. You can find that on any podcast player or at microbe.tv.
Thank you. And then Theodora and Paul, if you were us, what would you be reading or watching to learn more about this state of
Well, we watched the movie Contagion yesterday. We watched the movie Contagion yesterday, which is not.
no.
Yeah, no.
You know,
I didn't enjoy that so much.
I saw that too. I was so shocked that they actually used the term social distancing in the film. That's been around for that many years?
Yes.
So actually, it's although the scenario in that movie is worse probably is worse than the one we're facing now. It's quite prophetic, in fact, some of the aspects of it. I would just recommend for those who want to keep track of the epidemic, for those that are so inclined, there's a website at Johns Hopkins University by the Center for Systems Science and Engineering that has all the numbers in countries around the world and various regions in the United States. If that's something that interests people, it does me. I'm a borrower.
Maybe I hope we've inspired any youngsters watching to go into your field, because you're sterling examples of educated, knowledgeable, and you transmit, wrong word, you educate us in a way that we can fully understand. And I know Brad and I both really appreciate all of your work and your participation.
Hopefully we'll see you soon. If not next week again. We really enjoyed
Yeah.
it.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Okay.